Thank you very much, Mr. Chairman, also for the invitation. And so I'm coming back to the first talk today, and I'm going to talk a little bit about the challenges that we have when we are going on bypass. So I work in the German Heart Center Berlin. I have no disclosures. And teamwork and communication has been the focus of several papers that have been published, and this is a recent one I thought was quite interesting because it talks about teamwork and communication skills in cardiothoracic surgery. However, it mainly focuses on the surgeon, and it doesn't really take into consideration perfusion nor anesthesiology. I think this is a problem with this paper, but it says that there are, of course, a few things that need to be considered in order to improve communication during the operative phase. This is, of course, a culture of safety, minimizing adverse events by introducing this culture of safety, creating a blame-free environment, using crew resource management, improve cooperation and teamwork, and also look at patient transfer and ICU. And I know that this great GOS has done also these studies on how to hand over patients from the operating room to step-down unit. But the problem is, this is all very nice, and of course some of you may have seen this before. This has been developed, I think, in Edinburgh, so this is the non-technical skills for surgeons, and it has a few categories that mainly address how to improve communication and also to define the skills necessary for surgeons. But again, this is very surgeon-centered, and it just says that a surgeon should be aware of the situation, should make a decision, should improve communication, should be the leader. But as we all know, surgeons are operating on a patient, and how can a surgeon be a leader in communication and do a complicated operation? So this is something that I never really thought was possible in the first place. And this is supported by one older study. I have shown this before. This was done during pediatric operation. And as you can see, I think probably this is this is the surgeon as one, and this is the perfusionist, this is the anesthesiologist. So the surgeon really is the center of communication in this picture, but the surgeon talks a lot of times to the operating room nurse, hand me these instruments or whatever, and there's very little communication going on between the surgeon and the perfusionist, and there's even less communication going on between the surgeon and the anesthesiologist. And certainly there's no feedback in this direction from the anesthesia to surgery. Why is that? And one of the recommendations from this article is that communication patterns could be improved in this setting, and I clearly think that. So what kind of communication do we have in the operating room anyway? And there are certain certain levels. It's of course what many surgeons do. They command something, they have a direct action of communication. There are status messages, there are alert messages, there's goal sharing, explanation, and problem solving. And basically all of these levels of communication need to be addressed if you want to communicate effectively. So one recent paper looked at that, also pediatric cardiac surgery. Now it looks like the pediatric teams are more open to this kind of question. What about errors, and what about burden of errors? How can you change that? And so there was interviews with nurses, anesthesiologists, surgeons, and the safety attitudes were being requested. And the problem was that you can see that there are some red areas where there's a problem. For example, it is difficult to speak up if I perceive a problem with patient care. So, but 30% agreed. You say, okay, 70% say, no, it's not true, but 30% agreed. It's difficult to actually speak up in this operating room. Now, why is this 30%? It should be 0%. And again, nurse input is well received in the OR, 65% agreed. Again, a high proportion, not agreed. Morale is high, is 45%, and this one is even more of a problem. I'm unable to express this agreement, and OR staff are being briefed before surgery. This is clearly not acceptable. So I think the communication starts well before the operation and not just during the operation, so something must be reconsidered here. Now from aviation, there is